The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We're spending time this month with Dedee Caplin, who specializes in many ways in treatment of pain. And I am so intrigued because, as you suggested last week, when I look at my schedule on a daily basis, the places where I feel most inadequate are the areas where I think I know that someone is experiencing something here and I don't feel very well equipped to take care of it. So by the end of next week, I am going to be an expert.
Excellent.
I think I'm going to at least have a lot more context for what I ought to be doing. Do you have any conflicts that you need to disclose?
I do not.
So we've been talking here about disorders that very often result in functional impairment. So these are things that make a difference in people's lives, right?
Yep.
Yeah. So just some of the things that you mentioned: chronic pain syndromes, chronic daily headache, things like somatic symptom disorder, medically unexplained symptom disorder, but also things that, we sort of chip away at, things like chronic fatigue syndromes, long COVID, IBS. All of these things have dimensions that you're suggesting we ought to be approaching the pain part as aggressively as we approach all the rest of it.
Yes. I think the pain part is what's going to keep a kid at home. And the pain part is what's going to keep a kid not being able to function in their daily life, because pain keeps us in that state of high alert and makes it so that it feels unsafe and uncomfortable to do the things we're supposed to be doing.
And we probably all have patients, if we've been practicing for more than 30 minutes, we have patients whose response to this, or the family's response to this, has really been for this patient to really withdraw in a lot of ways. Kids not attending school, kids not doing things that they have otherwise loved, and that's a loss.
Well, and I think those chronic alert signals, those things that kind of tell us, stop, take a look, and make us suddenly aware of everything that's happening, can actually just be magnified and catastrophized over time. And that entire process can actually reinforce itself. So it makes it just really hard to get kind of up and over that hump and into the space of being able to know what to do. And so parent helplessness, patient helplessness, even provider helplessness can feed that cycle.
And I think you suggested last week, at least this is what I heard, that it's a good idea for me to try to become conversant enough with this process that it's not something that I save for when everything else has been excluded or has failed, but rather from a very early point, I should be thinking about how I can help someone.
Absolutely. I think the biggest thing that you can think about is the earlier you talk about it, the more likely you are to cue yourself and your families in on those things that you can do to help them feel better, to help them do more, and to help them move forward from that pain space, despite the fact that we know something's going on. So it's not going one route versus another. They can be parallel processes.
Yeah, that makes a lot of sense. So last week we talked about there are 5 domains that we want to address on a regular basis: the physical, the functional, the social, environmental, the psychological, and the cognitive behavioral. And I have to say, I still don't have a mnemonic device for that. Although I have to also confess that I have mnemonic devices left over from medical school. I remember the mnemonic device and have no idea what any of it represents. So I'm not sure.
So it's probably better we stay away from them anyway.
Exactly. So let's start with the physical domain again. As I address these issues with the patient, what changes should I be exploring in this domain?
I think the first big ones are really to just get a really solid, nice description of what is going on physically. What is your patient experiencing, right? And when I do this, or when I'm working like in a multidisciplinary clinic, a lot of the things we're looking into are frequency, intensity, duration, But also, does the patient notice any patterns? Is there anything that's making things better? Is there anything that is making things worse? Are there secondary physical symptoms that maybe weren't part of the primary problem that have now kind of popped up? And chronic abdominal pain is a perfect example for that, because a lot of times kids with chronic abdominal pain also start to have constipation, or also start to have IBS symptoms, or also start to not want to eat all of a sudden, which then starts to create nausea, which then starts to create other pain. So they can certainly, morph, and symptoms can certainly kind of process, but getting a really solid understanding of what's happening to the patient physically, I think, is a really great place to start.
I'm going to use a cultural reference here that will mean nothing to anyone but me, but I think that because of time pressures and because of the way we think medically, we're often looking to see the answer. It's like name that tune. I would like to be able to come to a conclusion with as little information as possible. I can name that tune in 3 notes. And the disadvantage of that is that there's probably some advantage, if I hope to be an empathetic listener, to encourage a patient to tell me the whole story. And sometimes rehearing the story allows me to both maybe, help with the diagnosis, but clearly to help with what they're experiencing.
Absolutely. And I think when people say, I don't have the time for that kind of a visit, my response is often, you understand by not doing that, you're inviting the patient to come back every 3 days for the next 6 months, because they need to get that story out there. And if we don't take that time, their symptoms start to escalate, their emergency days start to escalate, and suddenly you're seeing them anyway.
And sometimes even worse than that, for a patient to go, many places telling their story and being heard inadequately and not getting any relief. So what should my assessment include? How many labs or too many labs? I clearly should examine the patient and try to gain some understanding of how what implications of pain are.
So what I would say is, I think our general approach to things like labs and things like scans and all of those things that are in your toolkit for diagnostics is that you have to be highly aware that a negative result is going to increase patient anxiety, even if it relieves distress for you. The data is very, very clear on this. Patients are more stressed by negative results. They suddenly start to see themselves as the zebra patient, the patient who nobody knows what's going on with. And so when you do order labs, either have a very solid reason for doing it, or set the patient up with the understanding that I expect this to be normal. I am just crossing this one off.
So let me make sure I understood that correctly. The more exhaustive my inquiry, while it may make me feel better about it, I've probably made the patient more anxious unless I've really helped them understand the context. Okay.
Yeah, it reduces your credibility, because now suddenly you don't know what's going on. And all of these things that we tried, we don't know. And then you get to the end and you're like, okay, so now I don't know. And the patient gets to the end and they're like, oh my gosh, he doesn't know. And
yeah. So better yet to say, here's what I think is going on. If we do labs, to do them in as directed a fashion as possible.
Yes.
It's interesting because it's exactly the same thing that we heard from Karen James about rheumatology, that doing a bunch of rheumatology labs just increases the likelihood that you're going to get a weird result.
Maybe we should make it part of medicine all the way around. Always say why you're doing the test you're doing.
That's way too rational. In terms of physical domain, are there any helpful screens I should be thinking about?
I think the biggest screens you can do physically are the very obvious things, because, like, if we go back to, again, that kid with chronic abdominal pain, if they are constipated, it may not actually be the primary reason why they experience pain, but it certainly will help to treat the constipation. If you have a kid who's not eating very well and there's certain foods that are exacerbating them, you probably have a few avenues you can go down to say, hey, I don't think this is primarily what's going on. I think pain is your primary problem here, but this could be making things worse. Can we do that? And so I think don't ignore those obvious things that you as a physician are very aware commonly occur, because they are often present. And so it's not that either or, it's adding this domain in where you are very early in this physical process saying, it sounds like pain is one of the problems we're experiencing. So we might spend some time trying to figure out if there's something contributing to it, But we also have to think about pain as one of the primary problems, not as something that's going to go away if we just do this test.
Well, it gives us the wisdom that when someone says, I've tried that and it helps a little, but not completely, to say, exactly, that's what I was expecting.
One of our chisels. Yeah.
We will try to help with the other stuff too. And what should my treatment goal be in the physical domain?
I think the treatment goal in the physical domain is to help prevent escalation of unnecessary care, for sure. I think it's partnering with your patients and families so that you guys are on this route together. I think it is also setting up a management plan for when and how a patient should be concerned or worried. Like, when should they seek out care with you versus when should they say, oh, we're following our plan, we're doing okay.
Let's talk about the functional domain. What changes should we explore in this domain?
The big one for kids is, are they going to school?
Yeah.
And I think when a child stops going to school, stops being able to attend school, I feel like it's a red flag for everybody. We all know that kids are supposed to be going to school, but other activities in this domain certainly, fall into the category. Are they able to get out of bed every day? Are they able to take care of themselves and do the things that they can normally do? I've had patients whose parents are carrying them up the stairs because their legs are weak. I've had patients who are being fed very special meals separate from the rest of the family because they have a different way that they have to eat now. So what you're really trying to look for is, compared to what a child of this age, in this family, in this situation would typically look like, where's the departure from normal? Where are they not doing the things that they should be doing or want to be doing?
Are there any helpful screens?
Helpful screens. So there is a publicly available screener called the Functional Disability Inventory. We use it a lot in our pain clinics to really just give us a very vague gauge of, relative to where I expect this kid to be, how far off are they? And it's just a 18-item Likert scale measure, but it really does give us kind of a really quick eye on, okay, this kid can function, this kid can do what they need to do, versus, it looks like this kid's not sleeping and not going to school and not doing any of their physical activities.
What should my treatment goal be?
Treatment goal, return to function.
No.
You can't do it totally by yourself, but yeah, as a goal, we want to get you back to school. We want to get you back to your activities. It can't happen quickly. It's going to have to happen gradually. You're going to have to teach them about pacing and breaks and reinforcement and all of those things. So you're going to need a treatment team in place. If you have a kid who's not functioning, pulling in PT or OT, pulling in a psychologist is going to be a really good idea, because you're going to have people who are kind of motivating, supporting, and helping that child pace.
One conclusion I've come to over the last several years is that I really underutilize PT and OT in this sort of situation.
So I would say PT is critical, probably the most critical piece in getting kids back to function. It's what they're trained to do. It's what they know how to do. And if you get a physical therapist who is psychologically informed, they're very good at doing it in a way that doesn't increase patient anxiety and that actually gives parents a job, so that parents aren't interfering with the process but become part of the solution. We can use them really uniquely with these kids to actually get kids up and over that hump of not being able to function.
And it seems like it's a sort of career that actually anticipates that what we're aiming to do is get someone back to function.
Yeah.
Is not to pathologize it so much as to get them back to function. How about in the social environmental domain? What changes should I be looking for here?
I think what you're looking for is kids who don't spend time with their friends anymore. Families will notice changes in behavior. They'll notice changes in, they don't do their chores anymore, or they always seem to be needing something. A lot of parents will say their kids want to sleep with them or sleep near them. Those kinds of changes in the family structure are certainly things that I see often. I think more intensely, you might see parents who are asking for FMLA paperwork. You might see, people who are asking for support outside of, our family can't function anymore. We can't go on vacation anymore. We can't do those things anymore because the environment has to be so uber specialized. I think when you're talking about the school environment also, does the kid have a 504 plan? Can they take breaks at school? Is there a quiet place that they can rest if they're having a bad pain day? Can they have ice packs at school? right? Like those kinds of things can start to be woven into their treatment plan to support any environment where the kid's spending their time.
It sounds like with the idea there that those are the things that facilitate return to function.
Absolutely. And I think too, asking a kid who's, saying I have a 10 out of 10 pain and I can't go to school, oftentimes you can say, yeah, but we're going to kind of work on some things that make it possible for you to do so. And as we keep working, I really know it's going to be easier and easier for you to do that. And so your confidence in the process of return to function, of reprocessing, I think starts to really support the kid in being able to see that functional approach, that return to the different environments, and getting a bunch of people on their team is actually what's going to help.
Any screeners I should be thinking about on the social environmental?
I don't think there are great screeners. One thing that I often fantasize about is having a great screener for parent stress, because I think in this social environmental space, parent stress is something that largely goes undetected until it becomes problematic. I think as a parent, it's very difficult to watch your child consistently be in an uncomfortable space and feel like there's nothing you can do. So I think a lot of times I do ask parents and just try and get a read on what is your role in this process? Like when your child comes to you and says it hurts, what do you do? And I do talk to them and I do help families understand that as a family, there's going to be kind of jobs for everybody in that process. But just getting a good read on the environments that a kid is in is probably a little easier than trying to come up with a very specific way of looking at those things.
Excellent. Psychological domain. What changes should I be exploring here?
Look for anxiety. It is not always there, but when it's there, it is like a dark horse that's going to make everything worse. And fear and anxiety around pain usually limits response to pain, which then increases the fear and anxiety around pain, and it creates a negative functional cycle. And you really want to work against that functional cycle, right? You want kids to do more and feel less, not feel more and do less. And so sometimes you have to really help them reverse that process. So a lot of times I'm looking at, screeners for anxiety and depression, and any of the ones that are out there and publicly available are fine for that. I think most pediatricians' offices have screeners available for things like anxiety and depression and use them well already. So it's already part of the workflow. But certainly don't expect it for every patient, but when it's there, expect that it's going to get in the way.
In the conversation around, so you're telling me this is just anxiety?
I think you need to find a way in your own vernacular to say, I don't think this is just anxiety. It doesn't matter if you think it or not. It's a very non-productive way of thinking about it. It's just not going to get you anywhere. Unless your goal in treatment is to be right and not to get the kid back to function, you're really going to get nowhere with it.
Right. The two things are going to feed off each other anyway. And so if you can, you can look at all the domains. All right. The cognitive behavioral domain. What changes should I explore there?
So I think in terms of pain cognitions, there are some really clear ways that psychologists who work with kids in pain really think about it. And we look for kind of the difference between what are adaptive thoughts versus maladaptive thoughts. What are those thoughts I can have about pain that are going to move me towards doing something to help me feel better, versus what are those thoughts about pain that increase helplessness or increase distress or increase catastrophic thinking, which is then going to increase fear. So when it comes to kind of how people are thinking about pain, I feel like rather than being something we measure, it's definitely something you get a feel for. If you kind of get a feel from your patient that they have some catastrophic thinking about pain, that magnifying thinking, like it hurts, so I can't do anything, or it hurts and it's never going to go away, or those kids that come in and say, oh, I tried that didn't work, and I tried that and that didn't work. Yeah, don't tell me about that and that didn't work. There's a cognitive problem that is feeding into the pain process at that point. And you're going to have to convince them that working with a cognitive behavioral therapist is the way to go to actually improve some of those cognitions and get them working in the right direction. I think when it comes to pain catastrophizing, we do have a scale that's called the pain catastrophizing scale. We use it in a lot of, I love it, right? It's my favorite scale in the universe. It works beautifully. It says, okay, is there any helpless thoughts about pain? Is there any magnification from overfocus? And then is there any pain anxiety? It can be filled out by the parent and by the child. And I can actually have a conversation and hold those two things up and say, hey, one of you two is actually really putting a lot of focus on the feeling of pain. And they will look at each other and laugh and point to the person that it is. And it becomes a conversation I can have easily rather than a conversation around, well, I think you might be reinforcing your child's pain by your response, which never falls well.
No.
Right. And usually makes parents upset with us. And so I think with pain catastrophizing specifically, if it's something you're going to broach, having a way to do it that normalizes it is kind of the easier way to go.
How do you persuade people? It seems like there are so many settings where this is so important. How do you persuade people to try?
Therapy-wise, or to try anything?
Yeah. Well, I mean, we'll deal with anything later, but therapy.
Yeah. So therapy, I find it's a really easy sell, but it's because it's what I do for a living. And I'm pretty overzealous about it, right? Like, I'm like, oh my gosh, wait, look what you can do.
What do you mean I can't help you?
Well, and I can be excited for both of us for a long time, right? So so for me, it's a very easy sell, but I understand, like, you're trying to say, this is valid, this is legitimate, this is something I want you to do. And a psychologist is the right person to help you with this piece of it. And I think that for a lot of years and in a lot of our brains, we have been trained that it is either medical or it's psychological. And if I'm sending someone to a psychologist, we all have to assume it's psychological. And I would argue that I could be successful therapeutically with a patient without talking about any emotions, without talking about any anxiety, because all we're talking about is how your thoughts and how your behaviors are making things either worse for you or better for you. And if we can flip things so that you are actually working for yourself, you're monitoring what you're doing, you're retargeting your thoughts about pain, you're working on distress tolerance and discomfort tolerance and pain coping skills that are not medicines, that are actually behavioral techniques that turn those nerves on and off, a lot of times you can kind of get a foot in the door. I think for other kids, we really just keep it at a level of your nerves are sending the wrong signals to your brain. This is not a hardware problem. The hardware is working. The software is really struggling. And what a psychologist can do is help you reprocess that software. Right. And so really reprocessing pain nerves is a lot like training anything. It's a lot like toilet training. It's a lot like training yourself to change your diet. You know, if you have a patient with obesity who is really struggling with motivation for change, you would probably send them to a psychologist, not because they have anxiety, but because, gosh, you're in a really hard change process, and I know someone who can help you facilitate that process. So if you think about it, not just as a psychologist is there for mental health, but a psychologist is there for a behavior change process that's working towards function rather than against it, I think it becomes an easier sell. And yes, if there is anxiety, it is an easier sell because you can say, well, I think the anxiety is really getting in the way of the rest of this. And, you know, a psychologist can help with that. But I think if you just then send them, go to behavioral health or go find a therapist, you might actually get the same problem on the other side. There are a lot of therapists who are uncomfortable working with pain and functional problems. And they might say, well, this doesn't sound like a psychological problem. This sounds like a medical problem, and go back to your doctor. So I think you're going to have to foster some of those relationships and really kind of pick carefully the people that you're working with. But it's utterly doable and highly successful.
So how do you do that? How do you develop those relationships? Would I have to talk to people?
Yeah, you'd have to talk to people. There are ways to know who those people are. I feel very lucky in that I work in a department of pediatrics. I'm very well connected with a lot of pediatricians in a lot of different specialties. And so I feel like it's very easy for me to look at a patient and be like, oh, that's the doc for you, right? And I know my colleagues will send patients my way in the same way. I think having a system like a care manager in your office, even just call and say, how comfortable are you with functional disorders? How comfortable are you with like FND or somatic symptom disorders? How comfortable are you with patients in pain? Could be an easy way to at least knock off the people off your referral list who don't do it.
Right.
There are a lot of people who call me and say, hey, I have this patient. I know you guys do this all the time. Can you teach me how? And the answer is yes, because it is cognitive behavioral therapy, which a lot of therapists know about.
Yeah. I mean, it is striking to me how many families believe that dance class, piano lessons, and weight training will affect your ability to do something, but then struggle with the idea that therapy may be helpful.
Families are so apprehensive, but like I said, I think it's a cultural thing. I think we've really kind of put therapy in this category of people who need something because there's something deficient in them, and we can plug away at it. It's fine.
Right. But that's in the same sense that there's something deficient about you, and that's why you need weight training. I mean, it's
right.
It's perceiving that if I have this training that you're hoping to give me, that does improve my life.
Right. And I think that a lot of times, if you're viewing a therapist for a patient in pain, you should be viewing as someone who's guiding and someone who's coaching and someone who's modeling and someone who's supporting, not someone who's treating anxiety. Like, you really shouldn't be sending them for a pain disorder because you think it's anxiety. You should really be sending them for pain management training, for nerve reprocessing, for cognitive behavioral therapy that is focused on getting our thoughts and our feelings and our behaviors aligned towards function.
Yeah, here's the deal, though, Dedee. There aren't enough of yous around. That's the tough thing. So I really, really appreciate what you've taught us this week. Well, I'm sure there will be questions. For those of you who have questions, please send your questions to questions@vcurb.com. And we're going to talk some more about treatment next week. Are you willing to come back next week?
Absolutely.
What a relief. Good. Okay. So otherwise, we would just have to freestyle next week. I'll talk to you next week. Dr. Dedee Caplin. Thanks. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Paul Wirkus, who also composed the theme music. See you next time.